Welcome to RPA Institute and Research Center, New Delhi. This is the surgical video of intumescent pearly white cataract. On clinical observation, we can very clearly see a swollen and white lens with very shallow anterior chamber and tense and stretched out anterior capsule. But this very simple looking case landed up into a double trouble, that is, the anterior capsular tear extension into Argentinian Flag Sign during the course of Capsulorhexis. This patient also landed up into posterior capsular rent during the course of Nucleus management. So in this video, we aim to demonstrate how simply and how safely we could control both the complications successfully and come out of this very difficult and very challenging situation in this particular case. Now here I begin with the initial side port incision and then anterior capsular stain with 0.06% of the trypan blue. Anterior capsular stain is very important to enhance the visibility of the capsule because the capsule in these cases is usually very fragile and very thin, always have a tendency to extend to the periphery. So before initiating the Capsulorhexis, here I am injecting cohesive visco to pressurize the anterior chamber as well as to flatten the anterior capsule so that we could equilibrate the intralenticulaire pressure for the safe Capsulorhexis. This is the commonly used cystitome made up of 26 gauge hypodermic needle to create a puncture in the anterior capsule so that we could initiate the Capsulorhexis. But while puncturing the anterior capsule, needle creates a linear cut with open edges on both the sides. And here we can see that the open edges started radializing to the periphery, and there is a complete extension of the capsular tear to the periphery on both the sides. And this is how it has changed into Argentinian Flag Sign. Argentinian Flag Sign was first described by Daniel Peroni due to its distinct synonymous coloration to Argentinian flag. This is a potentially very dangerous situation because there is always a risk of this tear propagating around the equator and wrapping up into the posterior capsule, leading to posterior capsular tear or the vitreous loss. So before we start the phacoemulsification, we must restructure this capsular tear into some form of Capsulorhexis. So here I begin with the evacuation of some amount of the liquefied cortical material and then re-administration of the viscoelastic to pressurize the anterior chamber. Then with the help of the micro scissors, I am trying to give a small nick on both the edges of the torn capsule. Now these nicks are given to initiate the rhexis, and then with the help of the rhexis forceps, I'll be trying to repair the discontinuity of the tear by transforming it into a smooth semicircular incomplete rhexis along both the edges of the torn capsule. Now this is the first semicircular rhexis which is complete, and then the second semicircular is in progress, and this is how I complete the semicircular rhexis from the second edge of the torn capsule and have achieved reasonably good rhexis of 5 to 5.5 mm in size. Although everything was looking fine up till now, but this particular patient was preordained to face some different kind of fate. So friends, watch carefully. After the gentle hydro procedure, we found that the cataract is very soft and fluffy. It was just the cortico, epinuclear and nuclear complex, very soft material, so which just needed to be phacoaspirated. So with this slow motion phaco and very low parameters, I started the phacoaspiration of this soft material, and just at the initial stage itself, you could see that there was something wrong here at this point. This is nothing but a posterior capsular tear, possibly the extension of the anterior capsular tear into the posterior capsule. A very dangerous sight-threatening situation which has happened over here, and at this particular point we need to decide whether to proceed with the phacoemulsification or we need to convert it to some other procedure like small incision cataract surgery. But in this particular case, since the pupil is very well dilated, the cataract is very soft, the tear is very small, and up till now there is no vitreous prolapse. So we decided to continue with the phacoaspiration of the remaining cataract with very low phacoparameters and very safely and very slowly. After the sufficient amount of the cataract is removed, we stop the aspiration, but the irrigation is kept running. Remove the chopper and then through the same port we inject visco-dispersive material to pressurize the anterior chamber. Now this visco is going to tamponade the vitreous face and stabilize the remaining cataract so that it doesn't fall into the vitreous cavity. Once the vitreous face is stabilized, I resume with the bimanual irrigation and aspiration cannula, because this is the most reasonable option at this stage to remove the remaining cataract. Because in bimanual approach, we can very easily take the aspiration cannula between the two torn flaps of the capsule into the fornix and then hold the cataract, draw it, don't aspirate it inside, draw it and evacuate it from the wound so that we do not disturb the vitreous face. However, once the vitreous starts getting into the aspiration pot, we must undertake anterior vitrectomy with much advanced vitrectomy cutter with proportional linear suction control and controlled irrigation system. So here you can see the cutter is clearing the anterior chamber of vitreous to the level just below the posterior capsule and also at the same time aspirating the remaining cataract which is there in the anterior chamber. After the anterior vitrectomy is complete, the remaining cortical material can be very easily removed with the bimanual irrigation and aspiration cannula. So here we just need to hold the cortex and bring it to the center and aspirate. So you can see that now most of the cortical material has been cleared of the capsular fornices, and this is the final use of the cutter to clear the remaining vitreous tags or any amount of the vitreous which is there in the anterior chamber. Once the cataract removal as well as the anterior vitrectomy is complete, and since there is a sufficient amount of the capsular support available, we decided to go in for in the bag IOL implantation. So here I am trying to inflate the capsular bag as well as inflating the anterior chamber, and here goes the IOL. So important point to be noted here is the leading haptic of the IOL should be directly injected into the bag between the two torn flaps, and once that is done, the trailing haptic can be very simply slide into the capsular bag. This is how the IOL is fixed into the capsular bag in a torn capsule, a very well centered and quite stable IOL. Once that is done, here I begin to aspirate the visco material from the anterior chamber as well as from the anterior surface of the IOL. In this situation, I am not going to go behind the IOL because that may disturb the vitreous. And then finally, we have to make sure that the wounds are very tight, so there is no leakage. For that, we need to hydrate the wound to make it watertight and seal it properly. At the same time, inflate the anterior chamber to make it tight. On first post-op day examination, the cornea was crystal clear, vision improved to 6/9, IOL was well centered, well positioned with adequate posterior capsular support. To conclude, Argentinian Flag Sign extension into posterior capsule is a potentially dangerous intraoperative complication. Results with timely intervention and proper management may not be different from that of any uncomplicated case. Thank you very much.